So this patient's coming in for removal of a lesion. You can see there's some pockmark bleeding here. That's because we've had some anesthetic. Manny, how long has this swelling been here now?
It's about 3 years.
So 3 years. So this is not painful. This is a little bit away from the hair follicles. So whether these superficial follicles are called like a Butler cyst, I doubt it. This is more likely just an epidermal cyst. So you can see here it's draining a little bit. There's a bit of a puncture that's there. So I put a little bit of pressure on it. You can see there's a desire to put pressure back on that. So that's going to, because of that, then the capsule's already broken. So as opposed to just trying a linear incision, I'm just going to take out a little bit of an ellipse of tissue. It'll just make it a little bit easier. So this won't come out as clean from the standpoint of just popping this out, but we'll be able to get this out. And as long as we take the capsule out, it should be fine. Now remember, again, this is not an infected field. So anesthesia should be almost perfect here. So if Manny feels anything through this procedure, he'll just let me know, and we'll certainly add more anesthesia because we should be able to get that down better. Again, incision lines we're looking at, so you can see how when I put pressure here, those Langer lines develop. So we'll be doing a horizontal incision along this line here. And then beyond that, this should come out well for us. So again, why these happen in the first place. So epidermal cysts, or epidermoid cysts are sometimes called keratin cysts or epithelial cysts, and that's based on the tissue type from which they're derived. So, and again, the reason why I'm doing this as opposed to just a linear incision, when you have a puncta that's there, you have to take the puncta out as well because it's a communication with the surface. And it also means your ability to have a clean excision is compromised from the beginning anyway. So this is just a little bit simpler for ourselves. So, and then I got distracted, sorry. Why these form in the first place. So this type of cyst is usually believed at least to be a function of trauma. So trauma on the actual cell type causes that to push the cell type down into the dermis, and that forms a stable structure that then fills with keratin, which is why they're sometimes called a keratinous cyst. And you can see that as I'm putting the pressure, it wants to pop out. There's back pressure behind it. So this is like anything else. I find, there's no need to really speed your way along as much as some people like to. You could just take your time a little bit with this. It does make the procedure a little bit easier. So you can see there when I put pressure on it, that area is completely open, so the keratin just spills out of it. You can see how that just pulls out. That's all capsule. Like that. See how it's adhesed to the back there? Just trimming that tissue out. And see here you can see, this is where it comes right up, and that's where it's communicating with the surface. So that was where the puncta was. And you can see here, if I set it down, so this is just the cyst capsule. That's open now. That's all the cyst material in it. If I flip it over, you can see better. That's the actual capsule itself. So that's completely removed. As well, look in here, make sure that that's clear. And this should be pretty clean. So I'm looking in through here. You're looking to see any of that pearlescent sort of cyst material. And you can see here that it's just clean. There's nothing else that's there. So that's healed quite nicely. And again, since we took tissue out, so the whole debate always becomes here, should I put in dermal sutures? If I'm working with an area where there's going to be a lot of bending on it, so this is near a joint space, then for sure I'd put dermal sutures in. If I didn't take mass out, so if I felt like there was any tension on these sutures, then I'd also put some dermal sutures in. But because I didn't, then I'll just use superficial ones that I've never found in my career. I've never had any dehiscence with that. And dehiscence is just the process by which when you move your sutures, that the incision line opens up completely for you. So I'll just start at this apex here. And this is proline, which is a surface suture. We do 3 loops. I'm going to grab the tail and pull it through, and it should lay flat for us, just like that. And you can tell pretty quickly if this was, let's say you were mistaken and there was more tension being carried here, you can tell as you lay your sutures down that this is going to require more significant reinforcement. And there's nothing, if you're doing this procedure, let's say you'd change your mind and you want to sort of say, you know what, I want to add some dermal sutures. There's nothing wrong with cutting out your surface suture, sorry, and putting that in. You could certainly always do that. So I find too often we get critical of processes that we think we're committed to because we've started them off, but it certainly is no big deal of just cutting out a suture type and then adding in a different one and then going back to it afterwards. At the end of the day, if you feel the result is better and the patient's going to have a better outcome, then that's what I would certainly do. Now, will this recur specifically? Because the capsule was completely taken out, the cyst at this location shouldn't have any instance of recurring. But this is the part where there's some lack of knowledge that exists because for reasons we don't know, so even though the current theory for epidermal cysts is that the trauma is what incites the actual reaction in the first place, for reasons we're unclear on, people who are predisposed to cysts typically are predisposed to other cysts. So people who have these can form other ones. Not in this space, so because this was taken out completely, you shouldn't have any issues with this, but could he develop another one somewhere else? There's an argument to be had that he could. Now hopefully not. Hopefully this is just one of those situations where the trauma was just perfect, the situation was perfect, and that's where he had his cyst. And now that that's out, he should be fine. And you can see here, so this is, you see this here on this end, this little puckering here, we call, this is not even enough to sort of call it, but if this was more severe, we call this dog earring. When it's very minimal amounts, that's going to settle without any issue whatsoever. If it was very large, then sometimes you have to sort of address that from the standpoint of your suture technique, but that won't be any issue whatsoever, and that's laying nicely together, so that's all done. So we'll see those back in about 7 to 10 days and take them out.